Hello, my name is Jenny Pagel-Guile. I am the Executive Director, and on behalf of the National Pancreas Foundation, thank you for viewing this webinar. You are part of our mission, and as we focus on supporting the education of our care providers, patients, and our medical community. We also want to provide additional information, so you are able to follow us on Facebook. We have a new Facebook page. Make sure that you can follow us for all the up-to-date information and upcoming events that we have in your community. And we are also on a variety of other social media platforms for you to follow. In addition to your participation in this webinar, we are always looking for volunteers. So if you would like to be a presenter of a webinar and have a subject that you are interested in presenting on, or if there are events in your community such as Pancreas Bowl, we have galas, we have advocacy efforts, and a variety of opportunities to engage with the National Pancreas Foundation. And we look forward to seeing you soon.
Our moderator for this module will be Dr. Kevin McGrath. Dr. McGrath is a professor of medicine at the University of Pittsburgh and director of endoscopic ultrasound program at UPMC.
Thank you, Jenny, for that warm introduction and welcome. This webinar series is entitled Navigating Pancreatic Cysts, Classification, Treatment, and Management. This is an important and timely topic as we are finding more cysts due to increased use of abdominal radiographic imaging. The vast majority of cysts are benign, but it's our job to try to further classify these cysts and determine whether there is any malignant potential. We also want to avoid any unnecessary pancreatic surgery. Through these topics today, you'll learn more about classification, the further evaluation and management of pancreatic cysts, and whether surgery is indicated.
So with that, our three speakers are all advanced endoscopists here at the University of Pittsburgh Medical Center. All three have been trained in advanced endoscopy and have received specialized training in EUS and ERCP at UPMC. Their research and clinical interests are related to pancreaticobiliary endoscopy and pancreaticobiliary malignancies, along with acute and chronic pancreatitis and pancreatic cystic lesions. Lastly, our third module in this pancreatic cyst series will be presented by Dr. Harkirat Singh, who will speak on the management of the pancreatic cyst, touching on malignant risk, surveillance versus resection, our UPMC and societal guidelines for cyst management, and involving multidisciplinary approaches to treatment. Dr. Singh is a clinical assistant professor of medicine at the University of Pittsburgh School of Medicine and the medical director of GI endoscopy at UPMC Mercy Hospital.
Hello everyone, my name is Harkirat Singh. I'm one of the advanced endoscopists at UPMC Pancreas Cancer Center of Excellence. Thank you, Dr. McGrath, for the introduction. I thank the NPF for this opportunity to present how we manage pancreatic cysts in 2024 to all of you listening. So in this talk, I am going to briefly recap what are the kinds of pancreatic cysts. Two of my colleagues have already presented on that. This is just to refresh your memory. I'll be talking about the neoplastic cysts. Then we're going to talk about what is the risk of malignancy in these cysts. How do we figure out that what is the risk that some pancreatic cysts can eventually turn into cancer? We're going to discuss management of pancreatic cysts, which are symptomatic, which give symptoms to the patient. And then we will go and discuss management of IPMNs, which are the most common pancreatic cysts, and other mucinous cysts. And this is a little bit more complicated than straightforward. A brief recap. So there are different kinds of neoplastic pancreatic cysts, and they are basically categorized into two categories. One is mucinous cysts, which produce mucin, and these are mucinous cystic neoplasm and IPMNs. IPMNs are the most common cysts that we see in our practice, mostly the Branched-Duct IPMNs. There can also be a Main-Duct IPMN and a mixed IPMN, where they have a component of both Main-Duct as well as Branched-Duct. Then there are non-mucinous neoplastic cysts that we see in our practice: solid pseudopapillary neoplasm or tumor, cystic neuroendocrine tumors, and serous cystadenoma. We're not going to talk much about cystic neuroendocrine tumor. That's out of the scope of this talk and is a completely different vast topic. So before we start, what are the goals of management when we see a patient who has a pancreatic cyst? So the first thing is we need to accurately identify what kind of cyst a patient has. Is this a precancerous cyst, which can eventually turn into cancer, or is this a completely benign cyst? Once we know what kind of cyst it is, we risk stratify the precancerous cysts into low, intermediate, or moderate, or high risk. And this is important because the risk stratification dictates what a person will get in terms of their management. So what is the risk of malignancy or advanced neoplasia in a pancreatic cyst? And to understand that, we need to understand some caveats regarding this. I may use the term malignancy, cancer, or advanced neoplasia. Basically, advanced neoplasia includes cysts that have high-grade dysplasia, which is a step just before turning into a cancer, or they already have cancer, which is called invasive cancer. It is very challenging to determine exactly how much risky a cyst is, and the reason for that is all of the data that we have are from surgical series, and when somebody goes to surgery, you already know that they were high risk and the surgery was being done to either treat a cancer, or you already assume that they are very high risk for cancer. So the data has to be taken with a pinch of salt, and you will see numbers which vary widely. Very high quality prospective studies that you take thousands of patients who have pancreatic cysts and follow them over long term to see what happens to them. Good quality data of that kind is lacking. And for some of the cysts, we don't exactly know what is their precise biology. The easy part, we're going to go in this one slide, and then we'll get to the difficult part is what is the risk of malignancy in non-mucinous neoplastic cysts, the three kinds of cysts that we talked about. The first one is solid pseudopapillary neoplasms. We know that from surgical series that when solid pseudopapillary neoplasm is removed, almost 10 to 15% of them have invasive component, or they are malignant. These are the cysts which are solid and cystic. They happen in very young females, teenage to 20s. So if you're taking 100 of these out and 10 to 15% of them have an invasive cancer, you know that they are moderate to high risk. Because the patients are young, this is a rare tumor. Once we see this in a younger patient, it comes out because of higher risk of already existing invasiveness. Cystic neuroendocrine tumors are a little bit different and a big topic, which we're not going to cover here. Serous cystadenomas, these are the cysts which are benign. So once we know a cyst is a serous cystadenoma, we do not recommend follow-up because there is no significant evidence that they ever turn into cancer. And these can be symptomatic, but usually the symptoms are pain or pancreatitis, but not cancer. What is the risk of malignancy in mucinous cystic neoplasm? So MCNs or mucinous cystic neoplasms are one type of mucinous pancreatic cyst. We have data from surgical literature when these cysts were almost always removed. And in anywhere on pathology, 0 to 34% of them were malignant. And this is a wide range, 0 versus 34%. But we know that when these cysts are taken out and their size is less than 4 centimeters, the risk of malignancy is almost close to 0. So in the past, all of these cysts used to come out, but now since we know that smaller these cysts are, the less is the chance of any advanced neoplasia or malignancy. So the paradigm for their treatment has changed, and we kind of keep an eye on them than just take them out. So these would be, MCNs would be classified as probably moderate risk for malignancy. We move to IPMNs, which are the most common cysts and the most common cysts that we see in our practice. And sometimes it's difficult to make recommendations, clear-cut recommendation on these cysts, and we'll talk. So most of the talk will spend on these cysts. So to understand IPMNs, there are 4 major kinds of IPMNs we see. So in this picture, you see the pancreas, and this is the main pancreatic duct. If a cyst is originating from the Branched-Duct, we call them Branched-Duct IPMNs. If there are multiple of these spots or cysts in the pancreas, we call them multifocal Branched-Duct IPMNs. If the main duct of the pancreas is swollen, okay, this is called a main duct IPMN. And if a patient has component of both, a main duct is swollen and they also have a branched duct IPMN, we call it a mixed IPMN. To exactly understand what is the risk of malignancy or advanced neoplasia in IPMNs, we need to understand what are high-risk stigmata and what are worrisome features. These are certain characteristics either on imaging or in the blood work or symptoms of a patient, which tell us a little bit more about how this cyst may behave. So the high risk stigmata, as the name goes, makes a cyst high risk. So if a cyst causes obstructive jaundice, if there is a solid component within the cyst which is either enhancing on imaging, a CT or an MR or an ultrasound, which is above 5 millimeter or equal to 5 millimeter in size, if the main duct of the pancreas is involved and it goes above 10 millimeters, or if sampling of that cyst was done and it was suspicious or positive for something bad like a high-grade dysplasia or malignancy, these are called high-risk stigmata. Then we talk about worrisome features. Worrisome features are a list of features which in general makes us worried about the cyst, but they are not as bad as high-risk stigmata. These include patient getting pancreatitis from a cyst, if one of the tumor markers in their blood called CA19-9 is elevated, if they have new onset diabetes or they were diabetic before, but within the last 1 year, the diabetes got worse, if the size of that cyst is above 30 millimeters, if there's a nodule which is enhancing within the cyst, but it's less than 5, if the duct of the pancreas main duct is dilated, but it's not up to 10 yet, if the wall of the cyst is not like a nice thin wall, it has either thickened at one point, it's irregular, or it is enhancing on imaging, if the rate of growth of that cyst is more than 2.5 millimeter per year, if there is an abrupt change in the caliber of the main pancreatic duct, or if you see lymph nodes around, these things are worrisome, but they are not as high risk, but they are not completely low risk. So any branched duct IPMN, which is without these high risk stigmata or without the worrisome features, these are the most common cysts that we see, which are without high risk and without worrisome features. And most of these are cyst size less than 30 millimeters, and they can be multifocal. There are some longitudinal studies available for this, and if you follow these cysts over a 5-year or a long-term span, the risk of transformation reported for any advanced neoplasia, which could be high-grade dysplasia or cancer, can be anywhere from 0 to 8%, way less than other cysts. If the cysts are stable for 5 years and you see them further, and we have data till about 8 to 10 years, they have a less than 1% risk of progression. Progression would mean progression to a high-grade dysplasia or a cancer, or, for example, development of any high-risk stigmata. So now the branched duct IPMNs, which have worrisome features. Worrisome features are, again, not the high-risk stigmata. If you have one or more worrisome features, we know that it increases your risk of future development of pancreatic cancer or high-grade dysplasia. Again, we don't have great data for this. One surgical series had a bunch of patients back from 2022, and they basically retrospectively analyzed their data of the cyst that they resected, and they reported that if you have one worrisome feature, the risk of advanced neoplasia was about 22%. If you had 2, it was 34%. If you had 3, it was 59%. But if you had 4 or more, it was 100%. Again, this is surgical data. People go for surgery when we are suspicious that they have something bad going on. So this data is not absolutely accurate, but something that we can go by with a pinch of salt, like in surgical series that this was reported. In reality, the risk is a little bit less, but it is more than the cysts which do not have any worrisome features. So now the branched duct IPMNs, which have a high risk stigmata, these are the cysts which we get worried about and are higher risk. If you develop obstructive jaundice from a cyst, it is a very strong predictor that you have advanced neoplasia. Either you have high-grade dysplasia about to turn into cancer, or you already have invasive cancer. So if somebody developed obstructive jaundice from a cyst, there is a 75 to 83% chance that they may have a high-grade dysplasia or cancer. In some surgical series, because obstructive jaundice is a symptom, when these cysts got resected, almost 98 to 100% of the patients had cancer. So that's why if you develop jaundice, it's considered as high risk. Second high risk was an enhancing nodule, 5 or more millimeter in size. The sensitivity of that finding for presence of advanced neoplasia is almost 73 to 85%. Recently, there has been some controversy, and the most recent updated guidelines suggest that maybe 5 centimeters is a bit of a lower cutoff that we're going for, and it should be 10 millimeters. But it's still, we need more data to absolutely say that. But for now, 5 millimeter enhancing nodule within a cyst is considered a high risk stigmata. I want to briefly mention about additional testing. Usually the testing is based on CT scan, MRI, blood work, and sometimes we perform endoscopic ultrasound. This is a chart from a recent paper from our group, that when we do endoscopic ultrasound and sample these, we just don't test for cytology, we test for some genetic changes in these cysts. And these genetic alterations actually tell us that, one, it tells us accurately what kind of cyst it could be. Is it an IPMN or an MCN, mucinous versus non-mucinous, or another cyst? And if you have some high-risk mutations, which include the MAPK GNAS pathway, or TP53, SMAD4, or genes which are related to mTOR pathway, the chances of you having a high-risk stigmata, high-risk finding, including advanced neoplasia, is high. So if we find one of those, the sensitivity of that is almost 87% with a specificity of 98%. So this is something additional that we at UPMC do, which is not clearly mentioned in the guidelines, and we'll talk about it in a little bit. So that was Branched-Duct IPMN. We talked about, do you have high-risk stigmata or not? Do you have worrisome features or not? Or do you have nothing? Now, talking about the Main-Duct IPMN, if your main duct is dilated, and if it is dilated above 10 millimeters, these patients, when they went for surgery, anywhere from 36 to 100% of surgical series report that they had some advanced neoplasia. So that tells us if you have a main duct IPMN above 10 millimeter, you either have something already present, which is advanced neoplasia, or you are at a higher risk. If the duct size is between 6 and 9, this is a little bit controversial. We still consider it as a worrisome feature and not an absolute indication for surgery, but these are the people we watch very carefully. Moving towards management. So any cyst that is symptomatic, which can include recurrent attacks of acute pancreatitis, sometimes obstructive jaundice, or is the cyst is so large that it's causing pain, technically, if you are a surgically fit patient, we offer surgery because that's the cause of your symptoms. And when you take that away, the symptoms will go away. So, but these are not the most common patients that we see. The symptoms can be present. We see them in the cyst, but these are rare. The most common patient is a patient with Branched-Duct IPMN, which is usually found incidentally on studies, and they are asymptomatic. So there are 2 or 3 major things that we do when we see a Branched-Duct IPMN. One is we can survey them. Okay, we take a look at the imaging, which is at when the patient shows up, and based on what we see, we decide that this is not appropriate for surgical resection, and we survey them. Second option is surgical resection, and the last option is do nothing. And again, this is on a case-to-case basis. If you take 100 people who are 80 years old, and if they have no abdominal symptoms, if you do an MRI on them, 40% of them are going to have a pancreatic cyst. And most of those pancreatic cysts are going to be low-risk Branched-Duct IPMN. So we just can't take every cyst out, because pancreatic surgery comes with morbidity and mortality. And if a cyst has a very low chance of ever turning into cancer, you can't go and just take all those cysts out. So that is why it is important for us to figure out exactly what the risk of malignancy in a cyst would be and which pathway a patient will fit. There are multiple guidelines which have come out for Branched-Duct IPMNs. We had original guidelines from 2006, 2007. Then one major guideline, which was an international consensus guidelines, came out in 2012, which we followed. These guidelines were then revised again in 2017, which was the revised Fukuoka guidelines. And most recently in 2024, the guidelines were revised again. As more data comes, as we learn more about these cysts, the guidelines change. And later on in this talk, we will talk about the Kyoto 2024 modifications of the international consensus guidelines. Even the US societies came up with guidelines. In 2015, American Gastroenterological Association came out with their guidelines, which were controversial. Then ACG, the American College of Gastroenterology, published guidelines in 2018, and we have European guidelines. Lots of guidelines. The overall message that the guidelines send is kind of similar with a little bit of variation, and we don't follow exactly one guideline. even though the whole thing that we do is based on guidelines, and I'll discuss a little bit. It can be very confusing. So I'm going to present the management strategy for IPMNs based on the Curo 2024 guideline, which is the most comprehensive. This is a little busy slide. This is a flowchart from these guidelines. So branched-duct IPMNs with high-risk stigmata or worrisome features. Okay, so follow along with me. So we have labeled a cyst as a branched-duct IPMN, and these patients have one of the high-risk stigmata, which was either obstructive jaundice, enhancing nodule 5 or more millimeter in size, main pancreatic duct dilated to 10 millimeter or above, or suspicious cytology. They were biopsied. If you have any of those, okay, the chances is you have a high-risk cyst, which has either already has advanced neoplasia, high-grade dysplasia, or cancer, or you are at a very high risk of having those things in near future. So if you are a surgically fit candidate, we recommend surgery. Okay, there is not much debate about this, that these patients should be considered for surgery, either because they already have something bad ongoing or they are at a high risk. So this is the first thing we see whenever I see a patient with branched-duct IPMN. Do they have a high-risk stigmata? If they don't have a high-risk stigmata, then we evaluate, do they have any worrisome features that we talked about? Pancreatitis, elevated tumor marker, diabetes, new onset or worsening, size above 30, a mural nodule which is less than 5, the wall which is irregular, thick or enhancing, the duct is dilated but not 10 yet, if there is an abrupt caliber change, lymphadenopathy, or the rate of the growth. If you have one or more of these, then we carefully look at the imaging to see if they have one of these worrisome features or more. As we discussed in the surgical series, the more worrisome features you have, the higher risk you become. So when we see any worrisome feature, you get categorized as an intermediate or a moderate risk. So if you have more than one feature or you are symptomatic with pancreatitis, it is recommended that we carefully evaluate you for surgery. And here's when endoscopic ultrasound really helps us, and the genetics I showed you. So pancreatic cysts have fluid in them. That's the mucinous fluid. They are mucinous cysts. The fluid is secreted by the cyst lining, and it also sheds some cells into that cyst, and that's the DNA that we check for genetic alterations. And if we find genetic alterations which we consider are high risk and which is very new and strong data, we would categorize you as high risk. So depending on how many worrisome features you have, we again evaluate you for surgery. If you have more than 2 or 3, if you are surgically fit, you get surgery, or after careful evaluation of imaging, endoscopic ultrasound, and genetics we have available, we categorize you as you may not have anything now, but there is a decent chance you may develop some high-risk feature in future. So we either very carefully survey you or we send you to surgery. Of course, you have to be surgically fit. So these are branched-duct IPMNs with either high-grade or worrisome features. These terms can be confusing, so I'm repeating them again and again. So now branched-duct IPMNs without those features, which is the most common patient that we see. Okay, and the patients are usually anxious because anything that is reported on a CT or MRI report that you have a mass or a cyst in the pancreas, of course, everybody thinks that they may have cancer. So these are the patients without high risk, without worrisome features, and the management depends on the size. Okay, I'm going to go forward. So this is that part of the flowchart. If no high risk, no worrisome feature, and your cyst is less than 20 millimeters, the international consensus guidelines tell you repeat imaging in 6 months and then every 18 months if it stays stable. This time frame varies about different guidelines. Okay, there is data to suggest one way or the other, but sometimes you can follow them at 1 month, a 1 year interval. Sometimes these 18 months can be shifted to 2 years, depending on the stability of the cyst and how frequent a patient can get evaluation. So less than 20 millimeter, low risk cyst, you survey them in 6 months, assuming that they're stable, then you do every 18 months to 2 years, whatever guidelines you choose to follow. If the cyst progresses, for example, the size grows bigger, or now they have developed pancreatitis, or now they have developed diabetes, or if you develop any other worrisome features, then you reevaluate everything again, and then again go through the flowchart. If the cyst size is between 20 and 30 millimeters, then you repeat imaging at 6 months twice, and if everything is stable, you repeat imaging every year. And again, most cysts will be stable. If the cyst is above 30, so you had one worrisome feature that the cyst was above 30, but there was nothing else, and a comprehensive eval with imaging EUS yielded nothing else, then the recommendation is you can survey that cyst every 6 months. Again, some providers may choose a different guideline and follow these every 1 year. If they progress, you go back in the flow chart. How did they progress? Did they develop a worrisome feature or a high-risk stigmata? And then you choose surgery versus continued surveillance. We will talk about this a little bit later, when to stop surveillance. So these are Branched-Duct IPMNs without high-risk stigmata or worrisome features, which is the most common patient that we see. And after a good evaluation of imaging, plus minus endoscopic ultrasound, we decide this follow-up. So are these guidelines good enough? Okay, are these guidelines good? The whole goal of these guidelines are to select patients who are at high risk and get that cyst out versus low risk you can survey. Okay, so this is a publication from 2023 which evaluated diagnostic accuracy of the AGA, the IAP guidelines from 2017, not the 2024, on the European guidelines for detecting advanced neoplasia in IPMNs. And again, advanced neoplasia is high-grade dysplasia. It's right at the cusp of turning into cancer or already cancer. So this is over 15 years. They evaluate around 250 pancreatic cysts that were resected at surgery. Around 145 of these cysts were IPMN. So now they retrospectively applied these guidelines on them, that what would have the guidelines said in these patients. So they had 52 IPMNs which had advanced neoplasia, and if they would have followed the guidelines based on what their clinical situation was, the AGA guideline would have sent only 27% of these to surgery. The international consensus guidelines would have sent 94%, and the European guidelines would have sent 96%. So these are pretty good numbers. But they had 93 patients who did not have any high-grade dysplasia or cancer and were incorrectly advised surgery. So AGA would have sent only 8.6% of those to surgery, which is good. But the IAP and the European guidelines would have suggested almost 70 to 80% of these patients still undergo surgery. So even though the guidelines found 90+% of the patients which needed surgery, but they also sent patients for surgery who did not need surgery. So their conclusion was the European and the international consensus guidelines are clearly superior in detecting advanced neoplasia and IPMN as compared to AGA, but at the cost of higher rate of unnecessary surgery. And this is the dilemma we all have. We want to find patients who are going to develop cancer, but we don't want to do unnecessary surgery because pancreatic surgery is complicated and comes with morbidity and even mortality. So what do we need for management of IPMNs at this time? We need better risk stratification and decision-making tools. We really don't know exactly if you have some worrisome features, because cysts which are low risk, we know how to manage, we survey them. Cysts which are very high risk, we know to send them to surgery, but this is the middle cysts which have some worrisome feature, but no high risk stigmata. How do we exactly know which one to send for surgery and not? So we need more data and better tools for that. We need multidisciplinary approach to be followed at most places. We engage at our center in UPMC, we engage our pancreatic surgeons in any cyst which has a complicated decision making. And we need further improvement in molecular testing. We have made significant strides over last decade in accurately identifying cysts and identifying high-risk features, but we still need more work to do to figure out what earliest genetic change we can identify, which will tell us how this cyst will behave in future and take care of it at that moment. So that was IPMNs. Going to management of mucinous cystic neoplasms, which is the second kind of mucinous cyst. This is relatively easier management. So if you have an MCN which is above or at 40 millimeter in size, and if you're a surgically fit candidate, we suggest resection for those because the risk of malignancy is moderate. If you have an MCN, irrespective of your size, if you're symptomatic or if you have a mural nodule, that is also considered a cyst, which should be recommended resection. If you have an MCN, which is 3 to 4 centimeter in size, we could choose surveillance for these cysts. And again, this is a decision making with the patient. These may never grow, or when you survey them with imaging in future, they may go. So maybe surgery is in their future, and you discuss that with the patient. Would you, and the conversation is, would you like to see a surgeon now and get it taken care of, knowing that the risk of malignancy in a less than 3 to 4 centimeter cyst is low, or we can survey you and only get surgery if it grows bigger. So, and sometimes patients make your decisions easier. For cyst where the diagnosis is unclear, which is many times, we cannot say if this is an IPMN or an MCN. We follow the IPMN pathway. We assume it's a mucinous cyst. We assume that the likelihood of this cyst to be an IPMN is higher than an MCN, and then the flow chart I showed you is what's followed for these neoplasms. Main-Duct IPMNs. Any Main-Duct IPMNs which causes jaundice or has high-risk stigmata, the duct size is above 10, or they have enhancing nodule within it, we recommend resection. And the same goes for mixed IPMN. Mixed IPMN are the IPMNs which have both branched-duct and a Main-Duct component. And if they have a Main-Duct component, that kind of takes over, even though unless we have the path of a surgical specimen, we don't know if that Main-Duct got dilated by just the mucin secreted by the branch duct, or is the Main-Duct also involved? It's very difficult to tell, but we assume that the Main-Duct is involved. And if the duct size is between 5 to 9.9 millimeter, we usually survey these patients. This is a little controversial. Once you reach close to 10, most surgeons will operate, but between 5 and 9, we still survey them with more frequent imaging. Another controversial aspect of this is, when do we stop? Okay, the cysts are very common. Most of them are low risk. At what time do you decide, okay, we don't need to follow them anymore? AGA guidelines from 2015 said that if the cyst size hasn't changed after 5 years of surveillance, or a patient is no longer a surgical candidate, you cannot take care of this because they have cardiovascular issues, they are in age is above 80, 85, then you're not going to tolerate the pancreatic surgery, then we should stop surveillance. These were very controversial because if you have a 50-year-old, they have a 20 millimeter cyst, and you follow it for 5 years and nothing changed, we don't have good data to suggest that they may not grow. They have 30 plus more years to live, and the cyst can grow and turn into cancer during that time as well. So in our practice, we usually keep surveying a cyst, even if it is low risk, as long as a patient is a surgical candidate. And this is what is suggested by most guidelines. These are different guidelines, and I wrote exact wording that they use when should we stop surveillance. The consensus guidelines from 2017 said continue indefinitely as long as fit for surgery. There is an American College of Radiology guidelines from 2017. They said people who are less than 65, if for 10 years the cyst has been less than 1.5 centimeters or 15 millimeters, you can stop. The ACG guidelines from 2018 said surveillance should be discontinued if no longer a surgical candidate, and it is reasonable to assess the utility of ongoing surveillance in those who are aged greater than 75. So again, patients who are 75, 80, 85, it's a discussion with the patient, telling them what is your risk of ever developing into cancer, what is the chances you will ever reach surgery. And some patients make your life easy and say, I'm 85, I may have cancer at 90, 95. I may not live that long, or I may not be a candidate for surgery, so I don't want to undergo unnecessary MRIs or CTs. And there are some patients who will tell you like, hey, I would still want to know what happens to me. Do I develop a cancer or not? So it's like a mixed bag, but it is reasonable to have this discussion and stop surveillance once you know somebody will not get surgery. European guidelines said patients affected by IPMN without indication for surgery should be observed until they're no longer fit for surgery. And the most recent guidelines from the international consensus say if the cyst is less than 20 millimeters with no progression for 5 years, you can have this discussion with patients about the necessity of surveillance, even though we don't have the best possible data to suggest. If it's a 50-year-old with less than 20 millimeter cyst and hasn't grown for 5 years, I personally would not stop surveillance because there is a good chance average lifespan is 78 to 80, so they may live till 80, and then it's long enough time for me to decide this is not going to grow. So we usually continue surveillance for those patients. Take home from this talk. It is very important to accurately identify pancreatic cysts. We used to rely on imaging, which was CT, MRRs, or endoscopic ultrasound to define kind of cysts, but now we have some genetics which we can run on the pancreatic cyst fluid, which have made our life better in accurate identification. The risk stratification on these cysts is based on malignant potential. What cyst is a low risk of either already having advanced neoplasia or developing advanced neoplasia, moderate to intermediate risk, or high risk? And the management depends on that. Surgical resection for surgically fit candidates is recommended for any cyst which is symptomatic, benign, or precancerous. Low-risk cysts can be managed with just surveillance with imaging, and these are usually branched-duct IPMNs or MCNs without any high-risk stigmata or worrisome features that we discussed. Moderate to intermediate risk cysts are managed with either surveillance or surgery, depending on how many worrisome features they have. These are usually branched-duct IPMNs with one or more worrisome features, and MCN, which is usually less than 3 to 4 centimeter in size, and a main-duct IPMN where the duct hasn't reached 10 millimeters yet. High-risk cysts with high-risk stigmata, we recommend surgical resection unless there's a contraindication. The surveillance for low-risk cysts can be stopped at the point when a patient is not a surgically fit candidate, and always try to have a multidisciplinary approach with the input of your pancreatic surgeons when we make decisions for the cysts which are not low risk and not high risk and fall in this intermediate category. Thank you. That was my talk. And again, I'm thankful for this opportunity to present how do we manage pancreatic cysts in 2024.